We are privileged to have him as our first speaker, and I have no doubt that this lecture will leave us enlightened and inspired. To chair the first session of the day, may I call upon Honorable Dr. Das Gupta, a very well-known name in the field of hematology. He has 4 decades in-depth experience in hematology and leading medical institutions in India and abroad. Who does not know Dr. Das Gupta? Dr. Das Gupta's areas of expertise include interpretation of bone marrow smears and biopsies, flow cytometric immunophenotyping of hematolymphoid neoplasms, including measurable residual disease and other flow cytometric assays. Diagnosis of hemoglobinopathies, including newborn screening, investigation of chronic anemias, thrombophilia testing, and diagnosis of platelet disorders. Dr. Das Gupta has published more than 135 scientific papers in peer-reviewed international and national journals. He was a teacher and guide to many MSc and PhD students at the Mumbai University. May I request Dr. Das Gupta to introduce the first speaker of the day? Thank you.
Thank you, Shama, for your kind introduction, and thanks to Mindray for this fantastic opportunity to be here with all of you. I was kind of unlucky to have missed the previous ones for one reason or the other, although the Mindray colleagues have been connecting with me every year to see if I can join, and it's indeed loss on my part that I have not been able to be part of this fantastic activity that India conducts every year. When we talk about the development and growth in hematology, CBC is a very basic or very fundamental investigation, and it has been there for now decades. But it is also very fascinating that with advances in technology, in electronics, computer science, and things like that, the art and the science of doing cell assessment, blood cell assessment, has also evolved. And the fact that today we are having a forum like CUBE, where we mainly discuss these aspects, itself speaks a lot about the way science has moved, even in this area which otherwise is considered to be mundane. But I think all of us who are in this field will realize that every patient's journey in the process of management starts with by and large, a CBC. And in fact, this is one of the most common or commonest investigations that a patient undergoes. And there is a huge amount of information available in the data that we generate from these analyzers, and it's very challenging for all of us to decide about, and more so for people who want to go for hematology analyzers to decide which one to go for, because the advancements have been really phenomenal in all the brands. And of course, Mindray is a leader, as was mentioned by Shama, in this field, or Dr. Mukherjee mentioned that. So without wasting any more time, I would like to invite Dr. Anil Handoo. He has already been introduced, and he, as you know, has been the main force behind these various organizing of these sessions. Dr. Handoo is at the BL Kapoor, and again, he doesn't need any introduction. I feel privileged because he is a young colleague of mine, and we interact very closely on many fora. And it's indeed a pleasure to welcome Dr. Handoo to deliver his talk, and we look forward to hearing you, Anil.
Thank you. Good afternoon, everyone. And since I'm the opening batsman for the entire activity, I deliberately chose this topic. Now, when I talk about any cell in hematology, which cell do you think is the most glamorous cell? It's the lowest in number, but the highest in glamour, because it's the most colorful. And what defines hematology? All sorts of colors. So I thought, let me just talk about something, because if I keep giving you what we do in our lab and, give you the data, that all of you are anyways going to share with us. So I just thought, let us look at this glamorous cell, how it evolved over years. In fact, the history is almost more than 100 years old. So if I start with my talk, this is the place where I work, and I bring you warm regards from my Institute of Laboratory Medicine, B.L. Kapoor Hospital, and this is my lovely team, which works at the back. And of course, I don't have any significant disclosures to make except that this is a forum of Mindray on which we are playing the entire activity. Now, do you know, this is one activity which small kids do at school. I don't know how many of you have been through this activity with your kids, but they make them create a system wherein they are able to actually differentiate the coins in terms of their size. And this is one activity which a lot of people have done, at least I have done with my son many years ago. And I was very thrilled to understand it because I eventually collated it and tried to look at it from the WBC's point of view also. And if you look at impedance, that's what the instrument does. Now, historically, the WBC counts have been measured manually. And nothing has changed so far, by the way. A lot of people think that there is a standard methodology of WBC counting, and by the way, the standard methodology, even today, is a manual WBC count. So there's a lot of work which is currently going on flow cytometry, but we still do not have the exact standardized flow cytometry-based method. So there are lots of terminologies and techniques which are used for WBC counting today, which is electrical impedance, force volume, radio frequency conductivity, light scatter properties, and of course, use of dyes, which eventually give you cytochemistry. And of course, we talk about 5-part differentials, and people talk about 6-part and 7-part and 10-part, and I'll not get into details of that, but that's something which a lot of people discuss about, and all this is based on all of these techniques. Now, I told you historically, cell counts, especially the WBC counts, are still done manually, right? Using what? A hemocytometer. And if you look at the hemocytometer, eventually on a peripheral blood film also, you look at these kind of images which come onto your slides and you're able to count them. And again, these are arbitrary counts, which we all do. But I hope all of you have seen this image or dealt with this particular chamber sometime in your lifetime. At least in MBBS and MD, they would definitely want us to do this. A Newbar's chamber counting, and of course these corner squares. And then most importantly, we were using what was called the WBC diluting fluid, right? Now, I'm sure all of you must be wondering, I'm supposed to talk about analyzers, but here I'm standing in front of you and talking about WBC diluting fluid, manual WBC count, as to why am I even discussing it as on today. So I'll come to that in just another, maybe a minute or so. Just look at the constituents which you have here. You have glacial acetic acid and distilled water. You have gentian violet. And of course, you are also maintaining a pH at a certain point, right? This is what you're doing when you are doing a manual white blood cell count. And of course, when you do that, you charge the chamber and you count it in the grids. Again, no rocket science. This has been there for ages, right? Now, do you think this is any different in an analyzer than what you're doing here? The honest submission to that is the entire activity is almost similar. So you have a chemical reaction. What is the chemical reaction? You have a lysis, you have stabilization, you have permeabilization whenever you use a dye, and obviously in cytochemical analyzers you have cytochemistry. But all this needs to happen quickly. Now, if I give an analogy to cooking, whenever you try to cook, what do? You either increase the pressure, put it in a pressure cooker, or you heat it up, right? This is what you do. So let's do that. We heat it up, we put it under a lot of pressure, and all these reactions happen very quickly, and then we visualize it. How do we visualize it? We go to the current or a frequency or the light scatter, and any of these is eventually going to give us a digitized scatter plots and histograms. So from the manual counts to the automated WBC counts, it is nothing but a tiny journey of just adding pressure and temperature to it and making the reaction happen quickly. And that's how the entire process has evolved. So this is what the automated counting has been. You evolved from a classical impedance-based counting where it was depending upon the size of the cell, you were able to differentiate them and place them accordingly on a histogram. And subsequently, we know the Coulter principle, so I'll not get into details of that, but we also know the fact that every time the cell passes in through the aperture of the analyzer, it impedes the passage of the electric current and gives you an impulse, which eventually is taken on the graphic patterns and you're able to get your counts. Now, when we look at chemical reactions which happen in a classical three-part analyzer, essentially what you have a chamber, you have lysing agents, you have diluents, and you have cleansers, right? Because you have to clean it up. So for all practical purposes, you're adding the WBCs, you have two channels, the hemoglobin and the RBC channel, and you also have the diluent which is coming in, you have the lysis solution lysing the red cells in the WBC chamber, and from there eventually the counts come up and you're able to pick up your graphic patterns, especially again based on a classical Coulter principle which has been in existence for quite some time. And this is the classical graph which comes in front of you. Now look at the five-part of it. What happens there? Everything is virtually the same except that in some of the analyzers, we are now adding a fluorescence light or a different set of reagents. For example, we add a dye, and in that dye, we are differentially actually staining a particular cell and removing the others from the analysis. And then we get a baso channel wherein the lysis of the basophils will happen. You're able to get them separately as well. Again, in staining process, you can stain eosinophils separately, and this is what happens in the eosinophils, and you're getting all of these differentials differentially. There's also a concept today where they talk about instead of using a monochromatic laser light, use polychromatic light. Why does it help you? The polychromasia of the light itself gives you a lot of advantages in terms of picking up a lot of other information which can be there, and this is present in some of the analyzers. And who will forget this part of it where we use actually the cytochemistry to determine a different chemical analysis which is happening within the WBCs. For example, the myeloperoxidase stain, which is otherwise used on a slide, you can use it in the instrument. For example, the instrument which was prevalent all the while and now has been taken out is this analyzer from Advia, which would give you the peroxidase staining. So if you look at automated differential counting today, right from the differential counting using the impedance like the direct current, you would use radio frequency, you would use impedance, you would use laser light scatter, the polychromatic light scatter, the peroxidase chain reactions. You will also look at various channels defining whether you can pick up your nucleated red blood cells. The cell-specific lysing agents can be used. And again, differences in the temperature and the pressure that you use within the chambers will actually ensure that you're able to get the information as quickly as you can. Just to give you a quick recap of how the whole thing works, radio frequency conductivity is primarily the one which is used on the Coulter principle. The cells will pass through, and these pictures are classically from a classical Coulter counter from where the radio frequency, the conductivity, the volume conductivity, and the scatter would be used. Of course, they would also give you a typical scatter patterns which would differentiate the cells into different places. Added to it, the moment you add a light scatter, you would be able to get your scatter plots in a different analyzers at different places. And again, this is nothing but use of flow cytometry to differentiate cells at various sites. And when you do that, you can add cytochemistry, which I showed you previously. The moment you add cytochemistry, you're adding a differential within the counting of the WBCs and able to get your cells differently. For example, the ones which are not stained, you take them as large undifferentiated cells and are able to get you better information. So these are various plots which I've taken from various presentations just to show you and illustrate how the whole thing works. Of course, the fluorescence flow cytometry, which has been in vogue for quite some time. And of course, the cells, the way they come and present in front of you, all of these are also seen. You have the one which is on the left-hand side there, what is called the cube, the three-dimensional view of the cells, and basis that you're able to give what the different cells are. For example, if you look at this particular case, you're able to see very distinctly a green population, which is very big and larger one compared to the rest of the cells. And on the cube itself, you're able to identify them differentially, falling in a certain specific sequence in terms of the X, Y, and Z axis. And this was a classical case of CLL. Again, I'm sure a lot of you would have worked on this. This is something which comes in a classical figure of 8 appearance, which you see on WBCs, especially in cases of dengue. My colleague, Dr. Tina, had done some work on this previously, which we've presented in some of our previous conferences of CUBE as well. And of course, you also immature channels where you're actually going to get your immature counts. For example, the IG ratios or the IT ratios, which you would be talking about previously on the smear, have now been automated, and you're able to get your immature granulocytic counts from various analyzers, depending upon how much of immaturity is there. And you're also able to get what is called the nucleated red blood cell counts, as you can see in this particular analyzer pictures, which are coming from one of the Mindray analyzers. This is another thing which unfortunately did not really find its way a lot. And this was use of monoclonal antibodies for identification of various cell types. And this was primarily done by a company called Abbott, which was giving us an instrument called CellDyne. And in that, they added these CD4, 3, and 8 antibodies to identify T cells. In fact, it was shown that it gave a beautiful correlation with what was available on flow cytometry in these cases. And unfortunately, it never found its way in the real life. So I think with that, I have set the ball rolling, and I will quickly move on to my summary and conclusions. The automated analyzers here today are here to stay. We know that. We have been working on it day, right, left, and center. And we know that we are looking at WBCs from a standpoint where we are getting more and more information from them. In terms of the problems which we have on the hematology analyzers, I don't think the neutrophils and the lymphocytes do have any major challenges, especially in the normal regular samples. But yes, we do get problems when we are trying to pick up basophils versus monocytes and eosinophils. Of course, the basophils happen to be the worst. And there seems to be some thought process differences between us when we look at monocyte coming from an analyzer A versus a B. And we start thinking, oh my God, this monocyte count is wrong and that monocyte count is right. But if you do a head-to-head comparison, you'll realize that even between them, the R values remain very good. And of course, understanding your analyzer becomes very important. Most of us don't even look at the graphic data which comes out and are not able to understand how the graph is actually, kind of conversing with us and telling us what it is all about. If we start looking at that from that standpoint, that yes, I'm going to look at the data in a more pragmatic manner and trying to pick out information from there, a lot of disease states can be picked up from the data coming out from the hematology analyzers also. Additionally, we know that there are lots of newer parameters which I just touched upon in some of my slides where I showed that you can have immature granulocytes, you can have some other newer parameters, like the granularity index or the lymph index and stuff like that which can come up. We also know about the research parametric data which has been evolved so much in majority of the analyzers and has started giving us information directing towards a disease state. So if you look at all this information coming up in such a big way, I think the glamorous cells are becoming more glamorous by the part of the day, and hopefully we all start utilizing this information more and more. And as we deliberate for the next 1.5 days, we'll realize that a lot of work has been done in these areas which gives us information which is phenomenally good. With that, I would like to thank all of you for giving me this opportunity, and I would like to thank my team for supporting me all these times to ensure that we are able to deliver the information and hold these meetings as we have been. Thank you very much, and we look forward to any questions if there are for this talk.
Handoo, for tracing the history of WBC counting on the analyzers in a short span of time and beautifully doing so. And I'm happy that you also mentioned about the immunophenotyping as an additional parameter, which was very exciting as a thought. But somehow, as you rightly mentioned, it has not kind of taken shape yet. Although on a day-to-day basis, we all work in flow cytometry. We know how SSC versus 45 gives you a beautiful separation of all the various subpopulations. And you can use that to, kind of extrapolate and find the cells in these various regions. The other thing I just wanted to highlight was that when you are talking about these changes or the morphological differences, we are talking about fresh samples. And a lot of us work in distant testing scenario. Even in hospitals, there can be older samples. And those do impact the, the outcome of analysis more so in the white cell population. Say, for example, you will see that the monocytes will disappear. They'll go and sit in the granulocytic region in the scatter plots, and you get a low monocyte count when you have an older sample. So these are things which you learn along the way. And people who work in these areas, they need to be aware of these fallacies. Otherwise, you tend to give wrong, counts. And at the end of the day, of course, hematology analysis will give you a clue. That is not the end of the story. You will definitely, based on the flags and warnings, you will like to make smears and have a look at the smears and come to a final conclusion, because you can't really make a diagnosis of a disease, just from the hematology analyzer data. So that's a very important point for us to remember, because that is not, I don't know, at the end of the day, maybe once we have intelligence going to a level where they incorporate many more parameters and they are able to, also give us much more informative differential diagnosis kind of a scenario. But anyway, so thank you,
Thank you, sir.
Anil, for an excellent talk.
Thank you.
And if there is any one or two questions, then certainly we would like to entertain that and then maybe move on to the next presentation.
How much old sample will give a good reticulocyte count on the cell counters?
Look, I mean, this is a very, very tricky question to answer. In any case, we know that reticulocytes, even if they are kept in a sample, they will mature over the next 1 or 2 days. So for practical purposes, I would prefer to run my reticulocyte count on the analyzer as quickly as I can. But on a reasonable, kind of scale of error, if I may say so, I think probably about 8 to 10 hours should be a reasonable point of time, but not beyond that, because the moment you go beyond that, your reticulocytes will mature and you will not be able to get majority of your proper reticulocyte count, irrespective of whether you do it on the smear or you do it on the analyzer. The quicker, the better, as sir also already mentioned to you.
In fact, since you talked about aging of cells and the impact, and that's a very important area to look at. You may be aware that in certain analyzers, the mean cell volume tends to increase after 8 hours of aging. And these are the analyzers, I don't want to name, you will be able to guess, wherein they use detergents to take care of the poikilocytosis, as they call. But I'm not sure why should that matter to that extent. But in the process, what happens if you have done some studies and published that as well, when the sample stays at room temperature beyond 8 hours, you can see exponential rise in the mean cell volume. And you can therefore imagine the impact of that on the diagnosis of a case where, suppose this was a case of microcytic anemia, and you waited for 24 hours, 48 hours, the MCV goes to in the normal range. So you have already missed the diagnosis of microcytic anemia, which is very easy to make on a hematology analyzer if it is properly done. So these points are very important, and I would suggest that you should validate. I mean, at the end of the day, when you run a lab, you must validate the things that are told to you. We do not start a test and offer it to the patients till we have validated it in the lab, isn't it? So I think these points, like the question on reticulocyte count, Anil said the correct thing. I mean, these are cells which are dynamic, they mature, continue to mature. So depending on where you started, you will lose reticulocytes if you wait beyond a certain point. So I think 8 hours, 10 hours is a good time frame within which you should do the CBCs. Max 24 hours, not beyond that. But again, I don't want to get into that. I have some experience of this area, so I tend to get, tempted to get involved in that, but I don't want to continue anymore. So
and of course, keeping the temperature also in mind, the kind of temperatures that we work in, that's also extremely important in this whole scenario.
So